Hello people, this is Dr. Muskaan this side. So here I am going to share one beautiful case of cardiovascular system, and let's dive deep into this case and enjoy and learn together. Here is 55-year-old male who has came to hospital with chief complaints of shortness of breath, cough with sputum and fever which was on and off since morning. So first of all, I will tell you differentials of all chief complaints. If shortness of breath comes in mind, the differentials will be pneumonia, pleural effusion, pneumothorax, allergy, asthma, anaphylaxis, COPD, heart failure, cardiac tamponade, MI. Okay, if I am thinking about chief complaint is cough, so the differentials will be acute rhinitis, acute bronchitis, common cold, COPD, GERD, malignancy, sinusitis, pneumonia. Okay, now the other complaint was sputum. So sputum was black in color, so I will specify what are the differentials for black color sputum. It is tuberculosis or cancer, but other colors are serous. If it is pink in color, the differentials will be acute pulmonary edema or alveolar cell carcinoma. If it will be white in color, the differentials will be COPD, asthma. If it will be yellow in color, the differentials will be acute bronchopulmonary infection. And if it will be green in color, the differentials will be cystic fibrosis, lung abscess, bronchiectasis, pneumonia. If it will be red in color, the differential will be pneumococcal pneumonia. Now, if the chief complaint is fever, what will be the differentials? If patient have toxic look, the differential will be typhoid, septicemia and biliary tuberculosis. If patient has fever with marked perspiration, बहुत ज़्यादा sweating हो रही है, तो differentials will be septicemia, rheumatic fever, amoebic liver abscess, brucellosis. If fever is associated with severe myalgia, the differentials will be influenza, dengue, chikungunya, leptospirosis. If fever is associated with purpura, the differentials will be acute leukemia and septicemia. If fever is associated with convulsions, these all are differentials. You have to mug it up so that when you see the patient, all these things are just training in your mind. Okay, so I'm just also on the path of learning this. Fever associated with convulsions, the differentials will be meningitis, cerebral abscess and tuberculoma. If fever is associated with lymphadenopathy, the differentials will be TB, lymphoma, secondary syphilis, SLE and AIDS. So I told you all the differentials of the basic chief complaints. That was cough, you know that. Sputum, I told that. Fever, I told that. And shortness of breath also. I told those differentials. Now, on arrival, ABCS was normal. Means the airway was patent, there was no sign of respiratory distress, circulation assessment was normal, there was no shock in the patient, and sensorium was alert. It was oriented, E4, V5, M6. Okay. HOPI. Patient was apparently asymptomatic since morning when he developed shortness of breath, which was insidious on onset while watching cricket match. It was progressive in nature from MMRC grade 1, that is breathless while walking a slide uphill, to MMRC grade 3, that is short of breath while walking few minutes on level up ground, means on level more than 100 yard. It is associated with chest pain and orthopnea and paroxysmal nocturnal dyspnea. There was negative history of dyspnea, dust allergy, MDI, DPI use. Patient also complained of cough, which was acute on onset, progressive and productive in nature. It was associated with black color sputum. It was non-foul smelling, and there is negative history of hemoptysis. Patient also complains of fever, which was on and off in nature, progressive in nature. It was associated with weight loss and night sweats. Past history. He is a newly diagnosed case of hypertension on 21st March. Patient was also known case of diabetes 5 years back, but he stopped the medications and preferred lifestyle modifications to cure himself. There are no other comorbidities like thyroid, tuberculosis, TB contact, epilepsy, asthma and COPD, and HbA1c भी 5.1 था, so that means no diabetes. Okay, he was diabetic case but cure हो गया था. Past history, he never admitted in hospital with similar chief complaints. He take painkillers for pain in knee on regular basis, and the name of the medicine was unknown to the patient. Past surgical history, he has past history of fracture on right knee 5 years back, and he take painkillers for knee pain radiating to leg and foot. Personal history, bladder habits are normal, bowel habits not able to pass stool from last 3 days, sleep is inadequate. Patient was chronic alcoholic and chronic smoker, but he left smoking and alcohol 1 year back. He take mixed diet, that means he is non-vegetarian by diet. The decubitus patient is lying uncomfortably on bed, oriented to time, place and person. Vitals, BP, there was hypertension, there was tachycardia, pulse rate was 90 per minute, patient was febrile, 99.8 degree Fahrenheit was the temperature. On examination, mild parodil was present, mild icterus was present, and pitting edema was present. Clubbing, cyanosis and lymphadenopathy was absent. What are the differentials of pitting edema? Differentials of pitting edema can be some cardiac cause, can be renal cause, can be liver cause, it can be early stage fibrosis or calcium channel blocker drugs. Okay, so NYHA classification, when I have seen in that patient, it was class 3, that means significant decrease in exercise tolerance, because there was positive history of orthopnea and paroxysmal nocturnal dyspnea, which is specifically found in heart disease patients. So I have seen this classification NHYA, sorry. Otherwise, we generally check MMRC grade for shortness of breath. Okay, investigation picture. CPC shows anemia and thrombocytopenia. KFT picture shows increased urea level, hyponatremia, hypokalemia. LFT picture shows indirect hyperbilirubinemia. HbA1c was 5.2%. Ultrasound was showing moderate splenomegaly, mild pleural effusion and pericardial effusion. SARS-CoV-2 was not detected. ECG was showing tall R waves and slurred S waves, which is and there was ST elevation also on the another day ECG. So there was present of LVH and lateral MI. Okay, ESR was raised, it was 26. So differentials of raised ESR is neoplasm, infection, anemia, kidney and pregnancy. There is one mnemonic to remember raised ESR causes, that is napkin. Just search on Google Bob and you will get it. So in this patient there was anemia which was present, that's why there was raised ESR according to the differentials given and investigation picture given. Echo report shows normal LV function, calcified, severe aortic stenosis, mild to moderate AR, concentric LVH function, pericardial effusion present, no feature of cardiac tamponade. Okay. Cardiac markers was CKMB was less than 3 picogram per ml, troponin I was 0.02 nanogram per ml, Myo was 88.77 nanogram per ml. HbS-Ag was negative, HCV, HIV-1-2 was non-detected, NT-proBNP was 7408.84 picogram per ml. So NT-proBNP is N-terminal prohormone, brain natriuretic peptide. It is released in brain word इसलिए आ रहा है क्योंकि first time it was found in brain, otherwise it is hormone of heart and it is released when there is some stress in the heart muscles and it just stress it LVH में mainly and वहाँ पे वो breakdown होता है उसका protein का, due to which the levels of NT-proBNP are shown raised. Okay, chest X-ray picture was showing increased bronchovascular markings on both sides, right and left lung, and there was right side blunting of CP angle which shows right pleural effusion, and there was cardiomegaly also. So features of severe aortic stenosis were present in that patient as shown by echo report. The features were easy fatigue, decreased exercise tolerance, chest pain, shortness of breath, and yeah, that's it. So the diagnosis of this patient is ASA grade 4, NYHA class 3 and acute coronary syndrome. Basically there is severe aortic stenosis because there is hypertension, there is suddenly ECG shows changes, and then echo report shows acute severe aortic stenosis. Yeah, so I hope this listening to this case have added some knowledge to your brain. And yeah, I just want to add one point at end. The patient's sputum was black in color, and AFB report, acid fast bacilli, was not having Mycobacterium tuberculosis. It was non-detected. Patient even didn't have any history of tuberculosis in past or TB contact. So it was unknown to me that why black color sputum is there. So if you people are aware of this, just add some knowledge to me and comment why there is black color sputum. That's all. Dr. Muskaan is signing off now.